Hello, everyone. Um, Thank you for coming to the Thursday to 15 or medic teaching session um, on mental health or psychiatry. My name is Haz. I'm an F1 in Stoke. I'll let Nandini introduce herself.
Hi, I'm Nandini. I'm an FY1 in Glasgow at Monklands Hospital. I think we're just going to wait for a few more minutes until most people are here and then start the session.
Cool.
And then, of
Yeah.
course, if any of the information is triggering for you too much, please feel free to leave the session at any point in time. You can always message us on social media and we can provide a link to the teaching session and slides as well if you prefer to watch it in your own time because it's too close to home for you.
Thank you. I think we'll start at 5 past. Cool. Let me
Yeah.
just see. Do the slides work? Yeah, they do. Yes. Okay, so it is 5 past. I think we've got a good number of people here. So, just to explain the format, I'm sure we have people who've been to one of our lectures before, but we try to do it slightly differently, where it's more question based rather than lecture, us just telling you information. So, we've got a list of questions, and the first half or third of this session would actually just be going through the questions. So, we'll have a timer. We'll give you about a minute to answer the questions, and then we'll just click next. And I guess if you have a piece of paper, write down your answers, and then the second part would actually be us explaining the answers. So we'll go through the question, the answer, brief clinical knowledge, and then from there, maybe even going back to the question saying why was this and maybe not this and stuff. So if you are ready, please do have your papers and a pen. Yeah, we got, I think, 17 questions. Again, unfortunately, we can't cover every single topic, but here are some of the topics that we'd like to do. This is more, again, just testing your, SBA or short answer question knowledge and that skill. Please do put questions in the group chat. If you have any, we'll try and answer them at point. We want this to be as engaging as possible. If so, there isn't really much for us to say in the first half. It's just going through the questions. So hopefully you have your pens and papers ready. There's about, I think, 17 questions, but 17, I'm getting a nod. Cool. Okay, then. So we'll start a timer. All the best. Question, and then I will just click next, basically. Okay. So here's your first question. Okie dokie. Hopefully that wasn't too quick, but I think a minute is standard for answering a question. So hopefully you got your answers written down. The plan now would be to go through each question. So Nandini did half, I did the other half, and we'll go from there. Again, any questions, please just put it into the group chat. Also, I'm going to put a feedback form while Nandini's talking, so please do fill it out. It helps us as well as medic teaching for, building these sessions. Cool. I'll hand it over.
Sorry, I don't think I can click through the PDF.
Can you not put your mouse on it and move it and stuff?
No.
Okay, fair enough. I shall do the clicking for you. No worries.
So, question 1. A 16-year-old girl has presented with her mother to the GP. She has been refusing meals for the past few months and exercising excessively. She has a BMI of 17. Which of the following may be found on her blood tests? The correct answer was 2, which is a raised cortisol. So just to work through some of the other options. So typically, patients who have eating disorders and specifically anorexia nervosa, which is what the STEM is trying to get at, will have a low luteinizing hormone, low estrogen, as well as testosterone. And the way that I like to remember that is that oftentimes patients with severe anorexia are amenorrheic. And so you can imagine if those hormones are low, you're just not going to have a period. You may think that a patient's cholesterol would be low if they aren't eating anything, but it does paradoxically become high. Patients often have hypokalemia, and I try to remember that as they're not taking in any nutrients, so they're not going to be taking in any potassium. And they also often have a raised growth hormone. Next slide, please.
Yeah, tell me when to click next slide and then I'll do that. Yeah.
So the ICD-11 definition of anorexia is a BMI of less than 18.5, a persistent pattern of behavior of restricted eating or behaviors aimed at losing weight, and a fear of weight gain. Although I've heard just through my own clinical practice that psychiatrists are trying to move away from this definition of having a specific BMI or a specific weight to diagnose anorexia, and it's more based on patterns of behavior. So obviously from your history taking, you'd probably be able to elicit, at least from a collateral history, if not from the history from the patient themselves, that they are maybe skipping meals. Sometimes patients don't want to eat around their family, so they'll bring their meals up to their room because they don't want to be scrutinized for their patterns of eating. Patients often exercise excessively. They may take laxatives, which I think is typically thought of as a symptom of bulimia, but is also seen in anorexia. And they'll minimize their food intake. On an examination, you may see lanugo hair, which is these thin, almost whitish hairs that cover the body. These develop in more severe anorexia to try and conserve heat because they've lost all their body fat, so they're not going to be able to regulate their temperature in the same way. Patients may have a low BMI, although be wary of patients who have a normal BMI and are still exhibiting these behaviors. Patients with severe anorexia may be bradycardic and hypotensive, and you may also see that they have enlarged salivary glands, so it's worth seeing if they've got parotidomegaly. It may put you in the right direction with regards to a diagnosis. Next slide, please. So, as said before, when it comes to the investigations, it's really important that you do a full panel of blood tests because it tells you if people are having these kind of physical manifestations of their eating disorder. So, low FSH, low LH, low estrogen and testosterone, which oftentimes leads to the amenorrhea. You have a raised cortisol and a raised growth hormone. And you have an impaired glucose tolerance test with a low glucose. So the way I remember that is, again, they're not taking in any nutrients, they're not going to be taking in much glucose, and your cortisol rises in the body's effort to try and keep the patient euglycemic. Patients will have a raised cholesterol and they'll often be hypokalemic. In terms of managing these patients, CBT could be a really helpful approach, as well as for younger patients, family therapy. So that involves mum, dad, whatever parental figures are there, and can be really beneficial because obviously parents are the ones who are seeing them. They need to be able to deal with these behaviors. And if there are any problems in the family unit, it can help to address them. Antidepressants can be very helpful in these patients. First line, I believe, for anorexia is fluoxetine, which is an SSRI. In severe anorexia that may not be responding well with antidepressant treatment, you can use antipsychotics. And in patients who have some of the physical manifestations of anorexia nervosa, they may need to be refed through a nasogastric tube. This is something that you would do as an FY1. Of course, this would be directed by psychiatrists, but it's always good to remember what guidelines are available to help direct you as to whether this patient may need refeeding. And these are the MEAD guidelines. So it's medical emergencies in eating disorders, and they're really helpful, and they're relatively new as well. These can be found readily online. Next slide, please. So for question 2, you've got a 40-year-old female patient that attends A&E with confusion and pyrexia. She's tachycardic and hypertensive. On examination, she's found to have muscle rigidity and hyperreflexia. She takes sertraline and atorvastatin regularly, and she's been recently started on a new medication by her GP. Which of the following medications may have caused her presentation? The correct answer is C, which is sumatriptan. And if you hadn't guessed it, the patient has presented with serotonin syndrome. So out of the answers here, sumatriptan is the only serotonergic medication. So that's in combination with her sertraline is what has led to her presentation. Next slide, please. So serotonin syndrome is the name that's given to these group of symptoms that can occur with the use of serotonergic medications. So it's more likely to occur if a patient is on 2 or more serotonergic medications, but it may occur with just the use of one. It typically presents with autonomic dysfunction, so tachycardia, hypertension, and hypothermia. On a neurological examination, you may find muscle rigidity, they may be myoclonic, and they may have hyperreflexia, and they may also be quite confused. And I think what helps to differentiate serotonin syndrome from an infection, sepsis, or sepsis of unknown origin is that hypertension, which you wouldn't often see in patients who are septic, especially if it's a new hypertension. So it's important to remember and just have in the back of your mind which medications are serotonergic. So obviously we always think of our SSRIs and our antidepressants. You may also have patients who are on pain medications like amitriptyline. They may be on the monoamine oxidase inhibitors, which are less frequently used for depression, but for example, linezolid is on there. That's something that's used for the management of infections. Sertraline is sometimes used in Parkinson's, I believe. And sumatriptan is one that is commonly prescribed for migraines, and so you want to just check that that's not interacting with a patient's regular medication. And so it's always helpful to just maybe go through the BNF if you do have in the back of your mind that serotonin syndrome may be potential differential diagnosis. And that's why taking a good drug history from these patients or a good collateral drug history is really important. These patients are typically managed supportively, so give them IV fluids. They may be given benzodiazepines if they're particularly agitated. And in really severe cases, they may be given chlorpromazine and cyproheptadine because these act as like serotonin antagonists. Next slide, please. So question 3, a 34-year-old woman presents to A&E after an intentional overdose. She has been experiencing low mood for the past 3 months since the breakdown of her relationship. Which of the following is not a risk factor for the completion of suicide? So answer 2, previous suicide attempt isn't a risk factor for completion of suicide. And we'll go through some of the risk factors both for attempting and completing suicide in the next slide. Thanks. So firstly, just to go through the presentation of depression. It presents with low mood, as I'm sure you're all aware. anhedonia, which is kind of loss of interest in any activities or hobbies. Patients may often experience feelings of guilt as well, maybe guilt over past actions, maybe guilt for the way that they're feeling, the fact that they do have low mood. Some of the somatic symptoms of depression are poor sleep. Patients typically have early morning waking, which can help to differentiate it from anxiety, which typically presents with difficulty falling asleep. They may have poor appetite, a loss of libido, as well as poor concentration. And of course, your severity scoring depends on, firstly, how many symptoms are present and duration. So some of the risk factors for attempting suicide are if your patient is male, if they have a history of self-harm, a history of drug or alcohol use, if they have any chronic diseases, if they're older, if they're unmarried, divorced or widowed, and if they're unemployed. And then separate from that, you have your risk factors for completing suicide. And I think it's quite important to separate them out because especially as you go up in your training, you're going to need to assess, especially if you go into psychiatry, who are you most worried about sending home if they've had a suicide attempt. So it's always nice to have this in the back of your mind. So some of the risk factors for completing suicide are efforts to avoid discovery. So this could be that the patient has waited for everybody or family members to leave the home. Maybe they'll be going away for a weekend, or if the patient has gone elsewhere outside of the family home, somewhere that they don't think they'll be found, to attempt suicide. If this is a planned suicide attempt, as opposed to something that's spontaneous, that they've thought up just in the moment. If they've gone through the process of making final acts, for example, making a will, or like the example in the question was arranging for pets to stay with family members. That's perhaps not something that you may think of as a final act, but it's something that may be really relevant in actual clinical practice. Leaving a note, I suppose that does come under final acts, but it shows that there's a lot of forethought there when it comes to the suicide attempt, as well as if the patient's used a violent method to attempt suicide. So I suppose your main investigation is going to be doing a really thorough history from the patient, but you can use some symptom scales to try and help diagnose as well as determine severity of a patient's depression. You can use the PHQ-9 scoring method as well as the Beck Depression Inventory. But I think the PHQ-9 is free, and I think the Beck Depression Inventory is something you have to pay for. In terms of managing depression, patients can be managed with CBT, whether this is one-on-one with a counsellor or a therapist, or group CBT. If that doesn't work, medications can be used. First line is always SSRIs, and typically sertraline is the first one that's prescribed. And then you can always escalate from there. You can do an SSRI and an SNRI. You can try a tricyclic antidepressant. And for treatment-resistant depression, patients are often put on lithium. Question 4. An 80-year-old man attends the GP practice accompanied by his daughter. She is concerned that he may have dementia as he has forgotten her name several times, as well as details about his childhood. On further questioning, he tells you he has lost his appetite and has been suffering from poor sleep. His AMTS is 8 out of 10. Which medication is most appropriate to start for this patient? So the answer is C, which is sertraline. So if we go through the medications that are listed as options, you've got donepezil, which is an Alzheimer's medication. You've got amitriptyline, which is a tricyclic antidepressant. Can be used for depression, also used for nerve pain. Sertraline, which is an SSRI and first line for depression. Memantine, which is another Alzheimer's medication. And then levodopa, which is used for Parkinson's. And reading the stem, I think the differentials that would come to my mind are, does this patient have dementia? Because there's the daughter is expressing that she's concerned that that may be the case, as well as the fact he's had memory loss. Or does this patient have depression? Because he is expressing some of the somatic symptoms. And as we'll get onto in the next slide, we'll just discuss some of the key differences. So I don't know if you can read the chart there. It may be more helpful if you'd like to take a picture, but some of the differences between dementia, delirium is there as well, and depression. So in dementia, oftentimes especially early onset dementia, you'll have short-term memory loss, whereas in depression you get global memory loss. So if you go back to the stem, then you can see that the patient has, he's forgetting childhood events as well as the daughter's name. And so that's not really short-term memory, so it doesn't fit with a typical picture of dementia. Delirium, patients may also be confused. They may forget things as well. But the way that you differentiate it from dementia is that delirium may have a much shorter course, although delirium can last for months, but it's fluctuating. So whereas dementia doesn't fluctuate typically. And patients with delirium will often be hyperactive or hypoactive. So they'll either be really sedentary, sleeping all the time, or very agitated. Whereas with dementia, you don't see this kind of acute fluctuating course. Patients can obviously become agitated with dementia, but it does present over a longer period of time. In terms of dementia versus depression, in the earlier stages, patients with dementia may not be presenting with kind of the poor sleep and the loss of appetite, whereas these are typical somatic features of depression. And especially in the elderly, they tend to present more with these somatic features as opposed to coming out and saying, I feel low, I don't have interest in my hobbies anymore. And so I think those are some of the key differentiating factors, at least for me. Next slide, please. Thank you. So for question 5, a 27-year-old man presents to A&E after taking a paracetamol overdose with suicidal intent. He ingested 40 paracetamol tablets over a period of 2 hours before calling an ambulance to take him to hospital. So I think I've forgotten to put the answer in bold here, but the correct answer is B, which is start him on acetylcysteine immediately. Next slide, please. So when it comes to a paracetamol overdose, typically for most patients, you want to wait for a 4-hour paracetamol level. You want to see where that falls on this graph. If it's above the treatment line, then you would start treatment with NAC or acetylcysteine. If it's below, then it's not needed. However, there are some exceptions. So if the patient's had a staggered overdose, which counts as taking the pills over more than an hour, then you need to start treatment immediately. If the overdose was 8 to 36 hours ago, start it immediately. You don't need to wait for a level. Or if the timing of the overdose isn't known. And the criteria for a liver transplant, which is something you'd think about later on down the line if the patient's bloods aren't improving, are if they've got a pH of less than 7.3 more than 24 hours after an overdose, or all of the following: prothrombin of more than 100 seconds, creatinine of over 300, and grade 3 or 4 encephalopathy. And for these patients, you want to be discussing them with the National Poisons Information Helpline, as well as whatever your local liver unit is. For me, because I live in Glasgow, it would probably be the Edinburgh liver unit or the Glasgow liver unit. Next slide, please. So for question 6, a 19-year-old man presents with auditory hallucinations that have been present for the last month. He hears one voice that talks directly to him, commenting on his appearance and actions in a derogatory manner. He has no family history of mental illness. Which of the following is a first-rank symptom of schizophrenia? So again, I think I may have forgotten to put the correct answer in bold, but the correct answer is 3, which is passivity phenomena. Although all of them may be seen in schizophrenia. Next slide, please. So just talking about schizophrenia generally, some of the risk factors for developing schizophrenia are if the patient has a family history, if they are Black or Afro-Caribbean ethnicity, if they use cannabis. I think specifically cannabis, as opposed to all drugs, has been related to the onset of schizophrenia, and if they live in an urban environment. Some of the poor prognostic factors are if they have a strong family history or genetic predisposition, if they've got a low IQ, if it's come on gradually and they've had a prodromal phase of social withdrawal, and if there's a lack of an obvious precipitant. Next slide, please. So some of the first-rank symptoms of schizophrenia, which are typically how you diagnose schizophrenia, although I do think this has been taken out of the latest edition of the DSM, it's still quite prevalent in MCQs. So there's thought disorder, This can include thought echo, so they feel like everybody is hearing their thoughts, broad broadcasting, as well as thought insertion, which is the idea that somebody or some force is putting thoughts into the patient's head that aren't their own. That's number one. There's passivity phenomena, which is actions, impulses, or feelings which are being imposed on the individual. So maybe the individual feels like they're being told to hurt somebody else, and they feel that this isn't them that's thinking that. They feel like there's some other sort of force making them feel this way. Auditory hallucinations, so typically 1, 2, or 3 voices talking directly to the person and commenting on the person, and delusional perception, so believing phenomena that isn't there. Some of the other symptoms of schizophrenia are lack of insight. Patients can be really agitated. They can also become catatonic. They often have disorganized speech, and they may have neologisms, which are these kind of new made-up words that are only known to them. And they may have a really flat affect as well. Next slide, please. So some of the investigations that you do, again, really thorough history. It's always key in psychiatry. But you want to do routine bloods because you want to rule out any sort of organic cause. You may also want to take some serum lipids because these can become quite important when it comes to initiating treatment. You want to do a urine drug screen because there are different recreational drugs as well as alcohol that can induce psychosis, and that's a potentially reversible cause. And you also want to do a CT head on these patients if you do suspect that there may be an organic cause. In terms of management, patients are often started on antipsychotics. CBT can be really helpful for these patients as well. And for patients that have severe schizophrenia, when it's indicated, and often patients who are catatonic, they may undergo ECT, which is electroconvulsive therapy. Question 7. A 23-year-old male patient attends for a review of his treatment-resistant schizophrenia. He has no other significant past medical history. His bloods show the following. So a hemoglobin of 130, a white cell count of 2.4, platelets of 276, 0 neutrophils, lymphocytes of 1.7. Which medication is most likely to have caused his blood results? The correct answer is D, which is clozapine. And I think 2 key factors are obviously the deranged blood results and the fact he's completely neutropenic. He's got agranulocytosis, but also just in the stem it says treatment-resistant schizophrenia. So clozapine isn't normally started until a patient's tried at least 2 other antipsychotics. So that could point you in the right direction. Next slide, please. So here's a chart with a list of some of the antipsychotics, as well as some of the typical side effects and adverse effects that may occur as a result of them. So in terms of typical side effects from antipsychotics, they may develop extrapyramidal side effects, which includes Parkinsonism, akathisia, which is this restlessness, dystonia, and dyskinesias. And tardive dyskinesias are particularly like your lip smacking, etc. They may develop hyperprolactinemia, which can lead to sexual dysfunction, amenorrhea, galactorrhea. Patients also may have metabolic side effects, so weight gain is typically seen in a lot of these patients, and that can lead to the onset of type 2 diabetes. And patients may develop neurological side effects such as seizures. The first generation antipsychotics are generally worse for the development of these side effects. So these include haloperidol, chlorpromazine. Your atypical antipsychotics are a bit better in terms of their side effect profile, but they can still cause all of the above side effects. Clozapine in particular is known for causing agranulocytosis. Any of them can cause it, but in terms of multiple choice questions, it'll be clozapine that's the correct answer. Next slide, please. So question 8, I think, is yours.
Yes, question 8. A 21-year-old woman presents to the emergency department reporting suicidal thoughts following an argument with her boyfriend, long-standing difficulties with relationships, frequent arguments with friends and family, denies any paranoid thoughts or unusual beliefs, sometimes hears her voice in her head describing negative thoughts. During the consultation, multiple superficial scars on her forearms. You do not note any unusual speech or evidence of delusions. So this one is borderline personality disorder. The answer is A. So let me give my explanation first, and then I'll come back to it. So, I mean, this is an example of classical EUPD, or borderline personality disorder, fluctuation of mood. Another important thing just to highlight is in personality disorder, the patient needs to display this behavior before they were 18 and then also continuing after 18. So because, in the history it was persistent behavior, then you can think about personality disorders. So yeah, borderline would be fluctuation of mood, issues with self-harm, issues with forming relationships or wanting to be in relationships. They would say that in relationships they can be somewhat fine, but then outside is where they get this fluctuation in their emotions. In terms of paranoid schizophrenia, they have difficulties in trusting people. Schizoid is when you have a cold personality, that you're actually non-reactionary to different situations. Yes. So then when I go back to the answer for this, I've explained why it is borderline. In terms of paranoid, it wouldn't be paranoid because she says she doesn't have any unusual thoughts or beliefs. In terms of schizoid, she doesn't have this coldness in her character because she's displaying a fluctuation of her emotions. It wouldn't really fit that sort of criteria. Schizophrenia wouldn't necessarily be that because we've not really explored, or the patient hasn't said anything about psychotic type symptoms. So that's the reason why it is A. This one is mine as well. Yes. It's yours, Nandini. Okay.
So question 9, a 47-year-old man presents to his GP practice for a routine checkup. He mentions in passing how he believes that the COVID-19 pandemic was fabricated by the government. His speech pattern is disorganized. On questioning, he has no friends as he does not trust others easily. He tells you that he has been considered eccentric since he was young. Which of the following diagnoses is most appropriate for this patient? So again, this is another personality disorder question. So the correct answer is C, which is schizotypal personality disorder. And just going through the latter two, so autism spectrum disorder, I don't think this man is actually showing any symptoms of autism at all, but I think patients who are like this, who may be considered somewhat eccentric, could potentially be misdiagnosed with something like autism. So it's really important to be able to clearly differentiate these personality disorders and be able to compare and contrast them to something like autism. In terms of avoidant personality disorder, these patients typically avoid responsibility for things. They hide behind any sort of authoritative or parental figures, and he's not actually expressed any sort of behavior like that. And then in the next slide, we're going to talk about the differences between schizophrenia, schizotypal, and schizoid. And just to go back to autism, he's not actually expressed any kind of repetitive patterns of behavior or a need for a particularly structured environment. Although he did express that he has difficulty with socializing, but it comes from more of a place of paranoia, which I think is what can help differentiate this patient in terms of it's actually a personality disorder as opposed to something like autism. So something I always struggled with was differentiating these three different diagnoses. So for schizophrenia, a patient is experiencing hallucinations and delusions. And in schizotypal and schizoid, they are categorically not experiencing hallucinations or delusions. So the patient expressed that he thought the COVID-19 was fabricated by the government, which it's an odd thought, absolutely. But first of all, this is a thought that is surprisingly shared by many people. It's not an isolated delusion, just for him. And on further questioning, you would have seen that he is kind of in touch with reality in a way that schizophrenic patients are not. All of these patients do have interpersonal difficulties. In schizoid, they're completely indifferent to other people, whereas in schizotypal and schizophrenia, they may want to connect with other people, but they don't know how, and they may just feel more anxious about doing it as opposed to not caring completely. In schizophrenia, patients have completely disorganized thought. They'll use the neologisms, which are made-up words. They'll have really scattered patterns of thinking. In schizotypal, they may have slightly disorganized speech, but they don't have a thought disorder as such. And again, in schizoid personality disorder, they don't have a thought disorder. So I think, just to summarize, I think schizoid, cold, completely indifferent to social interaction. Schizotypal, odd ideas, somewhat disorganized speech, but no actual delusions or hallucinations. Schizophrenia, hallucinations, delusions, not in touch with reality. Next slide, please.
Cool. This is mine. Long question, so somewhat paraphrase it. Patient comes in to GP, 30-year-old woman diagnosed with generalized anxiety disorder, already on sertraline. Today's come in with worsening of her symptoms, so does not feel sertraline is helping, anxious all the time, frequent episodes of heart pounding, struggles with sleep. You observe and she's distressed. So what would you do in this situation? And the answer is change the prescription to duloxetine. So let me just give some explanation about generalized anxiety disorder. So we're going to go through a few anxiety disorders in my questions. GAD is excessive worry about a number of different events. So if it's one particular thing that makes them anxious, then you're thinking about a phobia or another anxiety disorder. But because it's a number of events, or they're just generally anxious, that will be defined as GAD. When a patient comes in, you need to rule out these differentials. Hypothyroidism, cardiac disease, if they've got any arrhythmias or abnormal heart rhythms. Medications can induce these, and these are common ones that patients can have. Overuse of salbutamol, theophylline, corticosteroids, antidepressants. In the first few weeks, they can cause tachycardia or heart pounding, or actually heightening of anxiety. And actually, that's something that you tell patients before you give them an antidepressant. Caffeine as well. So in terms of management for generalized anxiety disorder, first is just general education about it. From then, you can go for low-level CBT. So that will be group-based. Then stage 3, that is when you're thinking high-level CBT. So that could be one-to-one focus. And then you're considering drug treatments. And then following there, it is a specialist would deal with it. So actually, GAD is normally treated by community-based teams or, non-specialists like GPs. So did I have a slide about medications? No, I didn't. Okay. So in terms of, if you go back to the question, normally you start an SSRI, you go to the maximum dose of it, and then from then you go to another medication. So sertraline tends to be given, and then the second choice is actually to try another SSRI or an SNRI, and that's what duloxetine actually fits in as an SSRI. Mirtazapine is an SNRI. Pregabalin can be used, but that's like, second or third line. Increasing sertraline dose, I think that's the maximum dose. Diazepam, that is more used as like at the height of anxiety that they take at the time. We're not at that level at this stage. That is mostly used like in hospital. So hopefully I've explained why the answer is A, or number 1. Okay. Question 11. 18-year-old sprinter preparing for the national athletics meeting, asked to see the team doctor, which is you, for unusual sensations in his leg. describes a numb sensation below the knee, apparent sensory loss below the right knee, and the non-dermatonal distribution. The doctor suspects a non-organic cause. This is an example of, and the answer is conversion syndrome. Okay, so let me start explaining about the different medically unexplained symptoms. So a lot of these are actually diagnosed by exclusion. You're meant to, look at organic causes, and then from then you're looking at these, psychiatry-related diseases that could be causing these somatic symptoms, these physical symptoms. Okay, so I'll break it down for a few. Somaticization is a multiple of physical symptoms that you develop over 2 years. Also, this patient tends to not engage with, wanting to diagnose their condition. So you need a long history of this and unrelated symptoms. Okay. Next one is hypochondriasis or illness anxiety disorder. This is someone thinking they've got a very serious disease when in fact, nothing is really going on, or they're hyper worried about certain things, or let's say they got abdominal pain, therefore they're thinking cancer. Now, obviously, your job as a doctor is to rule out the cancer, but if they're still maybe even distrusting what you're saying or refusing to accept, then you're thinking about this. Okay. Next is conversion disorder, which is in this case, it tends to be patients who just describe loss of motor or sensory function. They're not feigning the symptoms, they're not faking it. So let's say our patient that we have is an athlete. He's probably very stressed about an event, the national athletic tournament that he's going to, and then he develops these symptoms, these abnormal symptoms, you could say, this loss of motor or sensory function. So that's what we call conversion disorder. Fictitious disorder, that is when someone is faking symptoms. Let's say in this case, he doesn't actually have sensory loss, but then says, I've got this sensory loss. So he's not faking it at the end of the day. Malingering, also called Munchausen's syndrome. That's when you're faking it for a cause. Commonly, it's seen like, let's say in A&E, a patient may fake symptoms to want medications, and they're doing that on a regular basis, like, wanting pain relief because they've got some sort of addictions, or they're faking symptoms because they want to get out of something, or some sort of financial gain for, insurance or something. And dissociative symptoms is the feeling of feeling very separate to your body. Okay. So hopefully I've explained why it is conversion syndrome, because in our case, it is the loss of sensory function. Okay. And he's not faking it. Question 12, you're on a psychiatry liaison rotation. You've been asked to talk to an admitted patient with known bipolar disorder. Upon taking a history, you struggle to follow the stream of consciousness as he keeps saying things like, I went home to feed my cat. So fat I am, I really need to lose weight. I hope the postman he always speeds up in his red van, Dan, is my best friend at work. You suspect that his flight of ideas is linked by only rhyme or similar sounding words. This will be clang association. So let me go through some of these definitions that you need to know in psychiatry. Circumstantiality, that is when you ask the question, you go off topic, but you do eventually come back. You come back to answer the question, or you come back to the topic. Okay. Tangentiality is when you are asked a question and then you're just slowly getting further and further away from the topic. Each sentence may have an association, but at the end you're so far that the patient doesn't even probably remember what they were talking about, and they probably can continue talking. Neologisms, that is when a patient's forming new words or combining words. It's hard to describe until you really see it at the end of the day, but so they are somewhat making some sense, but they're creating these new words. Yeah. Clang association, that is in this case, this is where words actually start rhyming together or sounding very similar. I didn't actually put it here, but the thing that I get confused is clang association with echolalia, which is the repetition of certain words or the repetition of certain ideas. Think of it as like echoes or the repetition of a noise. Yeah. Word salad is actually you're just saying words that are very incoherent. Maybe even they're not actual words, and the sentences have no structure at all. And then nights moving, that's a quite severe presentation. If someone has it, that's a loosening of association and illogical leaps from one idea to the next, and you get that in schizophrenia. Okay, so this patient could have mania, but that's not quite the symptom. Aphasic speech wouldn't be that. Echolokia, again, we said that's the repetition of an idea. And the patient's not making up new words. These are words that we know. It's just that there's just no association, and it's, similar sounding. Okay. Question 13, 25-year-old man has a change in mental status of the last month. He stayed up for nights, writing 4 novels, not been eating and drinking, refusing to engage, started gambling during the consultation, easily distracted, sentences don't make sense, saying random words, no drug misuse. He has a history of depression, and he feels people holding him back from achieving fame. So the answer is bipolar type 1. Okay, so let me explain about psychotic disorders. So psychosis, the 3 defining features of it is hallucinations, could be auditory, could be visual, development of delusions. So psychosis is when you've got a impairment of understanding what is going on, impairment to reality at the end of the day. So hallucinations are where you're seeing or hearing things that may not be there. Delusions, these are strong beliefs that the patient may have. Or thought disorganization, that's your, alienation and all those sorts of things. All problems in the thought disorder, so like, as we talked about, the word salad and echolokia and all that. Associated features would be aggressive, agitated behavior. Again, it has to be persistent, because if it's more acute, then you could be thinking delirium. But if it's been lasting for a longer period of time, then you are thinking about psychosis. It can be associated with depression. You can have depression secondary to psychosis. In this case, it's not, and we'll talk about it why. Thoughts of self-harm can also be associated with this. So with psychosis, you need to think about the other differentials, and let me try and talk about the defining factors between that. So schizophrenia is the most common that can be associated with schizophrenia, but then, as Nandini had explained, you need the first-rank symptoms, and then you look at the second-rank symptoms, and then if it fits that criteria, then it will be that. Bipolar disorder, in our case, this patient has no depression and then is in a manic state, or it could be in a hypomanic state. So these patients mostly spend their time in depression and then develop the mania and hypomania. Whereas mania, you'd be in a manic state most of the time, the heightened, anxiety and delusional thoughts and gambling behavior. It doesn't seem like it's persistent in our patients. It only seems short term. And then what would end up happening is it'll come back into depression. Pubertal psychosis, that's a very severe form. That'll be in post-pregnancy. What else have we got here? Corticosteroids, it can be drug-induced as well. And normally the peak episode is in younger patients between 15 and 30. So coming back to it, it's type 1 rather than type 2, because there is these obvious psychotic symptoms holding back from achieving fame, disengagement, like you could say writing 4 novels could be hypomanic, but I would say holding back from fame, that's like delusional type thoughts. It's not mania, because the patient has past medical history of depression, and it's not schizophrenia, schizotypal personality disorder. This is not persistent behavior. Okie dokie. Question 14. 21-year-old woman complaining has been experiencing persistent intrusive thoughts and repetitive behaviors, specifically concerns about contamination and excessive hand washing, gradually increasing and having a negative effect on the hands as a result. And further questioning, persistent thoughts about harming others, avoiding sharp objects due to fear, All of this causes her to miss work and avoid social situation, causing a significant negative impact on her daily functioning. What's the most appropriate course of action? The answer is D, referring to secondary mental health team and starting treatment on SSRIs whilst you are waiting. So if you didn't know, in this case, this is OCD. So let me try and explain what that is. So obsession is when you got an intrusive thought. Intrusive meaning a thought that keeps on coming in your head and is very bothering and is repetitive to the point that it becomes very distressing to the patient. Compulsions is repetitive behaviors, and the patient feels driven to actually having to do it. That could be excessive washing of hands, or that's the classic example, or cleaning things at the end of the day. So you can have one or the other in OCD, but it has to be for a persistent period of time to have that diagnosis, and that's part of the anxiety umbrella. Okay. So in terms of treatment, mild would be you can have CBT, or you can potentially start ERP, but that is in moderates. You would think about using an SSRI, but you could hold it. Then you've got moderate OCD, then you start an SSRI, then you look to do your ERP. And then in severe cases, it would be actually secondary care referral for that. It seems to be a lot of OCD patients, when they do actually present eventually to their GP or psychiatry, that they're more moderate to severe, and that's why you end up starting to think about referring to secondary care services, because this is considered like a very advanced disease. So like when I was answering this question, for me it was either C or D, but I think once you get into the stage again to ERP, that's when you need to get secondary care involvement. And then whilst you're waiting for it, because it is an anxiety-related disorder, you would still give an SSRI while you are waiting. Most likely sertraline. Second line, you can give clomipramine. Okay. Question 15. 46-year-old driver attends the GP 3 months after he was involved in a road traffic collision. You take a full history. The patient is unable to remember details of the event, but getting into a car makes her anxious. She avoids driving. She's concerned she may lose income as a result. Has recently been compulsively purchasing clothes and electronics online. Is also having to rely on sister for help for certain tasks, such as cooking and cleaning a house, because Anne does not have the motivation for these tasks. And informs you the number of occasions recently where she's been described as reckless by her sister when crossing a busy road near their house. Which of these details would point towards a diagnosis of PTSD? The answer would be B, avoidance of driving. So we'll talk about the other symptoms as well and why that's actually occurring. So PTSD is when a patient develops a traumatic event, then they develop this heightened anxiety that if they were to be re-exposed to that event, they develop this anxiety. If it's within less than 4 weeks of the event, we call it acute stress reaction. And then you don't really do anything. That's the watchful waiting. After 4 weeks, if it's still persistent, then you're thinking PTSD. Here are the three defining factors for PTSD. Re-experiencing the event, so they can complain of flashbacks or nightmares. Avoidance of behaviors or the situation. So let's say in this case, it would be the car, avoiding being in a car. But let's just say she didn't like the honking noise, so then she'll avoid being around horns, for those horns that people press. So you would avoid being around there because that would somewhat still remind you. Another one is like, let's say army soldiers and they come back from war, and then certain smells would trigger them, so then they will avoid being around certain things or certain colors, for example. And then hyperarousal. So that's in that moment, let's say if you were in a car, of course being in a car can be stressful because the accidents can occur. And you need to be aware. However, being that hypervigilance, getting that over anxiety that would be considered abnormal, that's what hyperarousal is. Okay. So in terms of management, first 4 weeks, you don't do anything. That's acute stress reaction. but then after 4 weeks. Those that are military related, you can refer to Army resources. Trauma-focused CBD can be offered, and then also EMDR, rapid eye movement desensitization therapy. You can give an SSRI, but that's considered, it's not first line. I think from then you're probably referring to secondary services. So avoidance of driving behavior, that falls into one of the three symptoms that we talked about. Inability to remember the detail of the collision. Now, it could be, is it actually an inability, or are they just avoiding thinking about it? Because even them talking about the car accident, that can trigger their symptoms. Okay. Convulsive online shopping. It seems like this patient's developed secondary, coping mechanisms, and one is shopping. But that's not really PTSD related. Increased reliance on family members, that could just be this patient's got PTSD and then secondary depression, and they're not able to look after themselves. That's why they're having reliance on other people, as well as, I think she was saying, she's having financial problems. And then reckless behavior, again, that could just, it was reckless behavior actually when crossing the road, again, because of the heightened hyperarousal, maybe having that, but that's not classical of PTSD. That's more of a coping mechanism. Okay. So that's 50. I think this is the last one, or is the second to last one? Okay. Question 16. 75-year-old woman seen by GP with concerns of memory. Extremely worried. She cannot remember recent conversation. Husband confirms they have repetitive conversations. This has been going on for 5 weeks and started after the patient's sister unfortunately passed away. Over some period, she had low mood, low energy, reduced appetite, poor sleep, concerns, as reluctant to go to memory clinic and take diagnostic tests for dementia. Which of these factors will lean towards a diagnosis of depression? And the answer would be memory loss of recent events. Okay. Oh, diagnosis other than depression, so more towards dementia. That'd be memory loss of recent events. Okay. So, I know Nandini had covered this, so I'm not going to go into too much detail, but here are just the things that would lean towards depression over dementia. So short-term memory loss. In dementia, it will be short-term because they are able to remember long-term things, or like their background or memories with their husband or wife or kids. But short-term, they won't be able to formulate new memories, whereas in depression it will be more of a global amnesia, a global loss of memory. Biological symptoms are more seen in depression, weight loss and sleep disturbance. Patient worried about poor memory. In dementia, they probably don't have that cognitive ability to think about that, whereas in depression, unless it's severe depression, they are actually probably concerned about it as well, or maybe have insights. Reluctant to take tests, disappointed with the results. I'm not saying in dementia you could be agitated and aggressive about that, but in depression, I think because of that lack of affect and engagements, you wouldn't want to have tests on you. Mini mental state examination would be variable in depression, can be variable in dementia, but it's more variable in depression because, again, your mood can fluctuate. And then a global memory loss, as I said, whereas in dementia, it would be certain memories. It's normally short-term memories. They can't formulate new memories. It's long-term that they're able to retain. So in our patient concern over memory loss, that would lean more towards depression than dementia. In dementia, you wouldn't really have insights. Reluctance to engage in memory test. So let's say in dementia, you probably would be more on board with it. Short history, that would lean towards depression rather than dementia, and then sleep disturbance, that would lead towards depression rather than dementia. Okay. And then I think this is the last one. 80-year-old man with his wife presents to the emergency department. States he has been more forgetful over the past month, not being able to concentrate and continually leaving the fridge open. Wife expressed concerns that he's been seeing monkeys standing behind him on multiple occasions. Past medical history includes type 2 diabetes and hypertension over 15 years ago. Most likely diagnosis in this case will be Lewy body dementia. So let me talk about Lewy body dementia, and I'll briefly talk about the others. I found this more confusing, I guess, in the dementias, especially in the psychiatry. So what is Lewy body dementia? You get these Lewy plaques that form in your brain. it is classed as a dementia. You get progressive cognitive impairment, whereas in vasculotomy is stepwise deterioration. Parkinsonism is associated with Lewy body dementia. Visual hallucinations is also part of it as well, which we've seen in our case. In terms of diagnosis, it's normally clinical, but there are some, you can do a SPECT examination on these patients as well, which is using radioisotopes to actually identify where these Lewy body plaques are. In terms of management, it's actually very similar to other dementia conditions. Using donepezil and memantine are those that can be used. So let's talk about our case. Forgetful over the past few months, so that will rule out delirium. Then, as you can see, leaving the fridge open, that just solidifies more so that this will be dementia because unable to manage themselves. Then it is the delusions at the end of the day. So this patient says he's been seeing monkeys on multiple occasions. That's why it's leaning towards Lewy body dementia. Now, obviously, I threw in the type 2 diabetes and hypertension, but because of the pattern that it's like a progressive cognitive impairment rather than a stepwise deterioration, or let's say the patient was like, I recently had a stroke and then developed these symptoms. That's why you're not really thinking about vascular dementia for this case. Okie dokie. I think that's the end. So, thank you for listening. If you are still with us, please do fill out the feedback form. It is in the group chat. This really helps me and Nandini and our team a lot because we take this forward to improve our sessions. There you go. The feedback form is right there. Anything else you wanted to say, Nandini?
If you do have any questions, please feel free to... Oh, I see one. Would you mind please quickly showing the answers to 1, 2, and 3?
I shall skip back. I'm clicking as quick as possible. A few slides back. So I'll go to 1 first, and then I'll click forward. Okay, there you go. So number 1 was raised cortisol. Question 2 was sumatriptan. And number 3 was previous suicide attempts. Did you need anything else, Lauren, or was that all fine? I'd like to think that's all fine.
If you guys put with any questions after the session, please feel free to message on social media, on Instagram or Facebook. Someone will get back to you. And if you fill out the feedback form, we will send you the slides. So that's a cheeky little incentive there. Thank you all so much for coming. I hope you found it useful. Fab. See you later.
I'm going to head off, Nandini. I've got another meeting at 8:30. So, but thank you for doing this lecture. I enjoyed doing it.
Another question. So, why is it serotonin syndrome and not neuroleptic malignant syndrome? I think neuroleptic malignant syndrome. I'm just actually bringing up my notes. So, with that, I think it's typically caused by antipsychotics as opposed to your antidepressants and your serotonergic medications. That's the way that I remembered it in uni. And you get more hemodynamic instability, whereas you typically see hypertension in serotonin syndrome. So if you've got hypotension and hyporeflexia in neuroleptic malignant syndrome, I believe. Does that make sense? So antipsychotics are the precipitant in neuroleptic malignant syndrome, whereas it'll be SSRIs or serotonergic medications in serotonin syndrome. In neuroleptic malignant syndrome, you get hypotension and hyporeflexia, whereas in serotonin syndrome, it's hyperreflexia and hypertension. Cool. Any other questions? I'm just going to wait for one more minute because just in case someone is typing. Okay, I think we're done. Thank you all for coming. Hope you have a nice evening.
See you, everyone.
Bye.